All right. Yeah. Thanks everyone for joining Walker today for our conversation around Matt and Mar. I'm Brianna Yoakum. I'm the Accreditation and Professional Development Coordinator for Walker. I'm joined here by Jason Bliss, our Executive Director, who will be behind the scenes today. Garrett Kostin will be leading this conversation today, and I will be helping by monitoring the chat for questions. We will have some blocked out discussion times. So if you do put a question in the chat, don't think that we're ignoring you. We might get to it. We'll try to get to all of them in our little discussion times that we have set aside today. So yes, now I'd love to pass it on to Garrett and he'll introduce himself and we'll get this thing started.
All right. Thank you, Brianna, and thank you, Jason. Thank you to Walker for having me. And thank you all. I'm very appreciative that you've all found the time to join us this morning. This is a topic that I think is quite important, and I'm eager to share the information and the experiences that I have, and also some tips and suggestions for you all working in recovery residences. I also hope that you're all warm and toasty this morning. I was telling Brianna and Jason, it's freezing here in Olympia where I am, and the snow is still falling gently. Hopefully, by this afternoon, it's supposed to turn to rain. So I'm hoping for that. My name is Garrett Kostin. I am a fully licensed clinical social worker and substance use disorder professional. And my personal experience with, or what we could call expertise on the topic of medication-assisted recovery comes primarily from my experience working for 2 years as the lead care navigator with a medication-assisted recovery program in Seattle with Valley Cities Behavioral Health. And I supported hundreds of individuals in early recovery, early sobriety, in getting started on medication-assisted treatment for opioid use disorders as part of a clinical treatment team. And before we get into it, I'd like to offer just two sort of disclaimers or disclosures, just to let you know my perspective, where I'm coming from on this topic. First of all, I am a social worker and I'm not a medical professional or a prescriber. I'm qualified to provide information about these medications and also to facilitate access to resources for individuals who are interested in getting connected with a treatment team or a provider. But I'm not credentialed to make any final decisions about any individual's suitability for a prescription for these medications. Also, I don't consider myself an impartial source of knowledge on this topic. I acknowledge that I do have something of a positive bias for medication-assisted recovery because of my experience and opportunity to witness so many successes with the medications and how transformative the medications can be for individuals who maybe haven't been successful with other pathways to recovery. And also, I've in my work contended with a lot of negative opinions and misconceptions about medication-assisted recovery. So I'm quite eager and passionate today to dispel some of those myths and hopefully decrease the stigma around medication-assisted recovery and those who choose it as a pathway. All right. So as Brianna mentioned, feel free to make use of the chat box. We're also going to have 2 discussion times where you're welcome to unmute yourself and hopefully we'll interact directly. This is Understanding Medication-Assisted Recovery, or MAR, in recovery residences. And we have a lot of material to go over today. I'll show you the overview. For me, all of this is really interesting and important. So we're going to be moving somewhat quickly to make sure we get through everything and also have times for the discussions. And Walker will also be making the recording of this webinar available for you to review maybe with your staff, your colleagues, or even your residents. And we'll also send out the PDF of these slides. So to begin with, I'd like to go over some acronyms that we're going to be using in our presentation this morning. You'll see these in the slides, and I might use these acronyms. SUD stands for a substance use disorder, or what we can call it a diagnosed a dependency with a substance. OUD is opioid use disorder, AUD, alcohol use disorder. RR stands for recovery residence, and OTP is opioid treatment provider. So for our overview, this is our plan for the next hour and a half. First, we will go over some of the different pathways to recovery, which include more traditional approaches and also medication-assisted treatment and recovery. We'll talk about the goals, the risks or dangers, and the clinical outcomes of medication-assisted recovery. Then we'll have our first time for discussion. We'll go over some myths and facts about medication-assisted recovery. We'll go more specifically into medications for opioid use disorder and alcohol use disorder. I'll just put it out there at the beginning that currently there are no medications for the treatment of cannabis or benzodiazepine use disorder. The same is true for stimulant use disorder, although in the next section that we get to recent developments and updates about MAR, I will be sharing some of the latest about the development of medication-assisted treatment for methamphetamine use. Then we will get to the heart of what's really relevant for most of you, which is talking about what MAR looks like in recovery residences, best practices, suggestions, and some considerations to make. And then we'll wrap it up with a second discussion and Q&A. But before we jump into all that, I'd just like to take a couple moments to talk about why I believe this topic is so important and why I'm so appreciative that you all are here today and that Walker's given me the opportunity to present again on this topic. First of all, we know that the opioid epidemic isn't slowing down. It's by no means going away. I think that the COVID pandemic over the past couple of years has worsened it in some ways as people have been struggling more with mental health issues in general and had more restrictions on access to treatment. And that's why I'm really eager to get more people up to speed on the option of medication-assisted treatment and informed about what medication-assisted recovery can look like. So this is where I'm coming from. I assert that medication-assisted recovery has proven to be a safe and effective pathway to long-term recovery for many in the treatment of opioid and alcohol use disorders. We also know that misinformation about medication-assisted recovery feeds stigma and discrimination, which can limit access to these very viable treatments for individuals. Also, this is important for us today to be talking about because the exclusion of people from recovery community support and recovery housing based on their use of medications is unfortunately something that has occurred quite a bit in the past. Everything is evolving, and I'm happy and hopeful that we're going to be part of that continued evolution today. But the exclusion of people with these medications is actually against federal law, the Fair Housing Act and American with Disabilities Act. So we want to make sure that everybody that's accredited with Walker knows how to align themselves with the proper guidelines. Okay. Finally, it's important to work on expanding and welcoming, not excluding, any new members of the recovery community because we are all stronger together when the recovery community is diverse and robust with all sorts of individuals and different types of communities. Despite all of these points, Matt and Mar, I'll use those somewhat interchangeably and we'll discuss the differences. but Matt and Mar is still considered somewhat controversial in many recovery communities, and there's still a lot of negative bias out there. So here are some things to just sort of help make my point. The first is this information, these statistics about drug overdoses, specifically in Washington state. We can see from 2017 to 2021, every year, the number of overdose deaths has increased. Also, we can see that nationwide, just in 2021 last year, over 100,000 people died from drug overdoses. And of that, over 70% were linked with fentanyl, which is a very dangerous and powerful synthetic opioid. Overall, in general, opioids play a role or are responsible for over 70% of all the overdose deaths in the US. So these numbers really help us contextualize and understand why we are focused so much on broadening availability for these medications, specifically for people with opioid use disorders. This is interesting. Just as I was refreshing my slides and making some changes to the content, this came up in my news feed yesterday. This is from Como News, one of the largest local news networks in Western Washington. And we can see here that the headline is 6 arrested in federal drug charges in Western Washington in Whatcom County, and 85,000 fentanyl pills were seized. I'm having difficulty seeing the whole slide, so I'm going to make it smaller a bit. There we go. Let me see if that helps. All right. People are still coming in also, so I'm getting those messages. But here we go. So the situation is that six people were arrested, and the officials seized, as it says, 85,000 fentanyl pills, which you can see in the large picture, in addition to 2.3 kilograms of fentanyl powder, 6.2 kilos of meth, 1 kilo of heroin, 5 kilos of cocaine, 5 vehicles, and almost $200,000 in cash. For those of you who are unfamiliar with fentanyl or have heard of it but aren't up to speed on how dangerous it can be, basically any one of these 85,000 pills is enough fentanyl to kill several people. The equivalent in weight and size of about 10 grains of salt, just 10 little individual pieces of salt, of the equivalent of that in fentanyl is enough to cause a fatal overdose. And fentanyl, as I mentioned, is synthetic. It's produced in laboratories, and increasingly it's being added to and contaminating other supplies of drugs, including stimulants and opioids. So when we have this opportunity with medication-assisted treatment to give people a viable pathway that helps them stay away from any illicit substances that may be contaminated with fentanyl, we are really directly helping to reduce potential overdose deaths. So I'd like to go over some terminology and just make some distinctions between different pathways to recovery that we'll be touching on in this presentation. The first one is harm reduction. This is a philosophy that consists of practical strategies aimed at reducing dangerous and negative aspects of substance use for both the individual using and for the overall health and safety of the community. Medication-assisted treatment, when we talk about MAT, that is specifically talking about the medications that have been approved by the Federal Food and Drug Administration to support the health, safety, and recovery of individuals with SUDs. And it often works hand in hand with a harm reduction approach. So individuals who are accessing MAT treatment may not exclusively be seeking to stop their illicit substance use or their addiction to opioids or alcohol, but they are using the medications to increase their safety and probably increase their stability. And for folks who are exclusively on the medications but are not necessarily seeking abstinence at this point, probably they're not the individuals that are going to be appropriate or applying to recovery residences. Harm reduction housing is probably more suitable or accessible for them if they're in need of housing. Next, in the lower category, there's abstinence-based treatment, which is the traditional recovery model. It means complete refrain from using all illicit substances, sometimes all psychoactive substances, whether they're legal or not. And abstinence-based treatment is most often coupled with extensive peer-based sober support, such as 12-step groups and or professional treatment. Along with, in the category, the same category as abstinence-based treatment, we can put MAR, which stands for medication-assisted recovery. So MAR means the use of MAT, the use of a medication to support the recovery of someone with a diagnosed substance use disorder, but also paired with the individual's engagement with abstinence-based recovery supports and commonly professional psychosocial treatments such as intensive inpatient treatment, intensive outpatient treatment, counseling, etc. And the sorts of individuals who are using MAT as a component of their MAR, of their medication-assisted recovery, are most likely those who are going to be suitable for recovery housing. And because the recovery residences most frequently require engagement with sober support. So just to make it clear, MAR equals MAT, the medications, plus the goal of abstinence-based recovery. And commonly in it, that includes living in a recovery residence for at least a period of time. So this is another way to conceptualize MAR, recovery-based or medication-assisted recovery for opioid and alcohol use disorder treatment. We call it the three-legged stool. This is considered the current gold standard for the treatment of these disorders. And the three-legged stool, you can see here, is conceptualized as the three legs that support long-term recovery, that gives someone the best chance for successful long-term recovery, consists of the medications, psychosocial treatment, professional behavioral health treatment, often for mental health and substance use disorders, as well as community-based sober support. And this visualization actually comes from a publication from the National Alliance for Recovery Residences that I'm going to be talking more about, and we'll send it out to all of you. So this is really what we're talking about when we talk about MAR, a three-legged or a three-pronged approach to recovery. So let's take a minute to talk about the goals of medication-assisted recovery. Our aspirations and what we hope that will be accomplished for somebody who has decided to engage with these medications as part of their recovery. First of all, it's to provide those individuals with an additional option and new tools for recovery, especially for those who haven't had success with other models. Also, a goal of medication-assisted treatment is to, as we talked about, reduce overdose deaths by making illicit substances and unsafe use practices unnecessary and less attractive. If people can reduce their withdrawal discomfort, reduce their cravings for opioids and alcohol through use of these safely prescribed medications supervised by a treatment team, that's going to give them much less incentive to go out on the street and spend money on dangerous illicit substances. Also, the hope is with medication-assisted recovery is that it will increase the stability and safety, not only for individuals in recovery, but also the communities they live in, by eliminating related criminal activity and danger to the community. And also because someone is experiencing much less withdrawal discomfort, complications from cessation of use, and reduced urges and cravings, that therefore increases their stability and their social functioning, and eventually their ability to gain and maintain employment. It really gives them a leg up in becoming a contributing, functioning member of society. And finally, with MAR, the goal is to increase retention in treatment and reduce relapse frequency and reduce relapse potential. Give people the tools they need to be successful longer with fewer slips and relapses in their recovery. And that is done through the implementation of individualized three-legged recovery plans that include the medications, professional treatment, and community-based sober support, often peer support. So we would be remiss not to also acknowledge the risks or the dangers of these medications. But the caveat is that, interestingly, these risks are only relevant for the medication specifically to treat opioid use disorder. These risks do not apply to the medications for alcohol use disorder. But the risks of the most common medications for treatment of opioid use disorder, which are Suboxone or buprenorphine and methadone, is the largest risk is that there is a chance of overdose if these medications are misused. The potential for overdose with Suboxone is much lower than that for overdose with methadone, and certainly less than the liability for overdose with illicit street opioids. But it is possible if buprenorphine is used incorrectly, not as it's intended, such as doubling or tripling the dose, and especially if it's taken by those who have not been given a prescription. They have a low tolerance for opioids, but they get their hands on Suboxone and take too high of a dose. Also, as with all opioids and all central nervous system depressants, mixing Suboxone or methadone with alcohol or benzodiazepines is very dangerous. It causes depression to the central nervous system to varying degrees, and it can cause respiratory failure and death. So it's sort of another category of risk of overdose with these medications when they're not used correctly. Then there is misuse. There is a misuse deterrent built into Suboxone film, which is the formulation of buprenorphine that is it's sort of a thin strip of film, or I often say like a small piece of gum that is dissolved under the individual's tongue. Part of the formulation of Suboxone is naloxone, which is the clinical name for Narcan, which is actually reverses overdoses, kicks off all of the opioid or morphine molecules off of the opioid receptors. So naloxone or Narcan is actually part of Suboxone, and that is intended to prevent the misuse of Suboxone. However, individuals have figured out techniques to make the naloxone that's in Suboxone inert, to take away its action. And then that makes it possible that Suboxone film can be dissolved and injected, and Suboxone pills can be crushed and snorted, and somebody would be able to get a pretty powerful high from misuse in that way. And then finally, there's the diversion or misappropriation of these medications, specifically methadone and Suboxone, which have a street value. Somebody can be receiving a prescription but not actually taking their medication as prescribed, and then selling it or misusing it. providing it to others. And this is why regular urine drug screens are actually mandated to be conducted by providers of these medications and opioid treatment programs to ensure compliance and to reduce the opportunity for diversion. For example, what this looked like in the program that I worked with was if somebody had folks, after they were stabilized on the medication, they needed to give urine or have their urine screened for substances every 2 weeks. And if someone had received the previous weeks, if they had received a prescription for Suboxone, and 2 weeks later their urine showed no buprenorphine in their urine, and possibly no buprenorphine, but other opioids were present, that would mean that they would not be eligible for an additional refill until there was more counseling and work done with the treatment team. So we'll talk about some of the preventative measures that go into hopefully reducing the risks of these medications. But so now that we've talked about the goals of these medications and also some of the risks that come with it, the downsides, let's talk about the outcomes. Let's talk about what we know about the effectiveness and basically the effects for individuals. What does the research say about the outcomes for the use of these medications for folks in recovery? This is a powerful quote I found from Dr. Charles Atkins. His book from 2018 is all about opioid use disorders. It's subtitled A Holistic Guide to Assessment, Treatment, and Recovery. And he is focusing here exclusively on the treatment of opioid use disorders. But he says, without doubt, MAT can provide people caught in the life-destroying cycle of substance use disorders with hope and paths to recovery. These are evidence-based treatments and represent the current standard of care. People on MAT show higher rates of treatment retention and decreased illicit drug use, especially when medications are of an adequate dose. While not perfect, they unequivocally provide superior outcomes compared to treatment without medication-assisted treatment. So I hold that these are, although as Dr. Atkins says, they're not perfect, but they are the best tool that we have today to help the most people get out of active opioid and alcohol use disorder. This is just a slide that has links to a lot of the research that enables us to say that the medical community has reached consensus that medication-assisted treatment and recovery for both opioid and alcohol use disorders have been demonstrated to be clinically safe and effective, the gold standard for treatment of these disorders. The medications save lives. They help folks stay in treatment longer by decreasing the intensity of urges and cravings, and therefore reducing the chance for slips and relapses. Also importantly, these medications improve birth outcomes for women with active substance use disorders and alcohol use disorders, and that is can't overstate how important that is for the future generation of society. And finally, these medications support stability and sustained sobriety. And at the risk of just hitting the hammer a few too many times, driving this point home, medication-assisted treatment and recovery has been endorsed by many highly credible and respected organizations in the US and internationally. But here's just some of them in the US, including the American Medical Association, the National Institute on Drug Abuse, SAMHSA, the Substance Abuse and Mental Health Services Administration, and also the Centers for Disease Control and Prevention. So someone who is very anti-medication-assisted recovery is going up against the consensus or the opinions of all of these organizations and the medical professionals that work with them. So at this time, let's have a little opportunity for discussion. I pretty rapidly went through a lot of information about medication assisted treatment and recovery, and I'm really eager to give you a chance and to hear from you um, on these topics. Any concerns or negative opinions that you may have yourself or that you've heard about medication assisted treatment and recovery, and or also your opinion about why you think individuals on these medications are often considered not really sober by others in the recovery community.
Okay,
I
we
see
have,
two.
yep.
Yes, go ahead, Brianna.
Oh,
Thanks.
we have Esther Riley. Um,
Is Vivitrol considered MAT or MAR?
Yes, Vivitrol is. Vivitrol is actually can be used as medication to treat both opioid and alcohol use disorder, and we'll be talking a little bit more about Vivitrol. The reason that Vivitrol hasn't come up yet is that there is very little abuse potential or street value for Vivitrol, so it's not one that carries much risk.
Is it considered abstinence-based or?
Well, Vivitrol would be considered part of abstinence-based recovery because Vivitrol is actually for opioids. Vivitrol blocks opioids from having any effect. Vivitrol actually sort of creates a cap over the opioid receptors in the brain. So if somebody were to use opioids after having Vivitrol, the opioids would not be able to enter or cross the blood-brain barrier or have any effect on them. So
Thank you.
yes, you're welcome. Thank you for the question.
all right, and I seen Dana, you had
Julia?
your hand up.
Oh.
Did your question get answered or?
I just wanted to say that I really appreciate the medically assisted recovery
Mhm.
because some people in the recovery community really have a lot of stigma on, people who are on medically assisted treatment. So I just like that MAR.
Mm.
Thank you. Can you share, do you have any opinions about why that is, that there's stigma or bias against people in the recovery community who have decided to make use of medications?
I think it's just people's own personal bias about what recovery is. I'm pretty active in Narcotics Anonymous, and I did spend quite a long time on medically assisted treatment. And yeah, I just think it's people's lack of knowledge, or maybe someone who's never had experience with an opiate addiction of any kind.
Yeah, that's a good point. Not having personal experience, not having empathy or understanding of how difficult somebody else is struggling.
Mhm.
Yeah, thank you.
I
And we
feel like
have-
it's the long-term accountability. You know what I mean? When someone's going into dose every day, especially somewhere like methadone,
Mhm.
they're there and present every day, making a habit, starting a new path.
Yeah, and there's some developments about methadone and about how frequently folks need to go into dose that we'll be sharing in this presentation. So that's going to be interesting. Thanks.
Okay, Julia.
Hi, thank you. I was kind of wanted to touch quite a bit on what Dana was talking about, but there's a stigma of people trading one drug for another, I didn't, it took me a while to get onto it. I truly believe it's a gateway to recovery, right? It allows people the ability to access recovery. However, I think with the stigma part of it is some of the individuals, because there's always that 10% in any situation you go into, right, that just abuse it. But I have also, with my experience with, running clean and sober and being involved in clean and sober housing and being in recovery myself, I think there's also a struggle with lack of attention with the clients as far as the providers go, right? Not making sure or providing or doing what's best for the client kind of thing is what I see. It's kind of, I see a lot of people will go in and get their doses raised and things like that. And so now they're not maintaining, they're actually being high on it. And as a provider, we can't really say anything to them, but it's a struggle and it's hard, and it just feeds that stigma, I believe.
Yeah. You raised several great points. First of all, I loved how you said you believe these medications are a gateway to recovery for many or most people, and that was very, very nicely stated. You also brought up good points about that it's your opinion that it's likely a small percentage. You said about 10% of people who misuse these medications and do get high with them, or do take advantage of increased access to prescriptions for these medications, and that hurts the overall opinions and attitudes about all individuals using these medications. And yes, I agree that is unfortunate. And my response to that is to try to encourage everyone to know that, you know, no individual deserves to be negatively stereotyped because of the actions of others. But thank you very much for sharing.
Charnay?
Hello, thank you guys for being here. As a person who has had a child on methadone, and he's 7 and super smart and healthy and happy and wonderful, I actually, before I got on medicated assisted treatment, when I was using, I was like, why bother? Because it is trading one for the other. And so there's even this stigma within the people who are still actively using that, why bother going to methadone, because it's the exact same thing. So until I had the opportunity to try methadone and to, like the last person was saying, kind of open this gateway to my life, I still thought it was a terrible idea, because it was just, I might as well just use the real thing. So realizing that there is definitely still stigma from people who are actively using is another piece, I think, to just be aware of that's going on.
Yes, yeah, thank you for bringing that up. There is, we hear this often when we're talking about medication assisted treatment, and specifically with methadone and buprenorphine, Suboxone, that you're transferring your dependency from illicit opioids, from heroin or otherwise, to a medication that you're also going to be dependent on. And if you stop that medication, you're going to go into withdrawals. I always counter that with the difference is that for the illicit opioids, you're likely putting yourself in danger. It's certainly breaking the law to go out and acquire those substances. Also, because of the risks involved, people frequently have to resort to criminal activity to get the financial resources to support their habit. The difference is also with contamination and the increase of fentanyl in just the overall general drug supply in the US. For many of those reasons, to me, it makes sense that although you still will have somewhat of a dependency on a substance, with medication assisted treatment, specifically just with Suboxone and methadone, because the others don't cause dependence. But this is medication that is safe. It's formulated in a laboratory. It's screened for impurities. You know what you're putting in your body. Also, it's covered by insurance. You're not having to resort to criminal activity and theft to get the medication. And finally, you're not having to interact with unsavory sorts, drug dealers, basically. Instead, to make sure that you have access to the substance, you're going in, you're keeping appointments, you're engaging with a professional treatment team that is much more concerned with your overall well-being and health and supporting you than a drug dealer on the street. But thank you for raising all of those issues. And yes, that is something that we contend with in helping people understand the benefit of these medications. And maybe one more.
Beth, go ahead.
Hi, Beth.
Hi everybody. Thanks. So I'm a person in recovery, but I've worked in the field for 12 years, and it's been an interesting journey for me. I think that stigma, the basis of stigma is fear. And so I used to have a fear of people using these substances or being prescribed medications for recovery because I didn't know enough about it, and as I learned and began to integrate that knowledge into my practice, I let go of my fears. And so I think it's just a long-term learning process. And different groups, every group is different. Every recovery group, whether it's AA or NA or CA or EA or OA or what, any A or, smart recovery or whatever, it's, they're all different. Every single group, not, fellowship wide, there's some literature available, and I don't think everybody reads it or reads it more than once. And so, stigma is something that, it's a fear that keeps the person who has the fear safe, and it also disrupts communication and the ability to build relationships, but not everybody is aware of that or knows that. So that's all I wanted to say on the topic. And as I learned more, I became more open-minded and better able to engage with everybody. So thanks. Glad you're here.
Thank you. I'm so glad you're here, and I'm so glad that you shared your personal perspective. It was really powerful. What you made me think of the cliche, knowledge is power. You said stigma results is an outcome of fear and lack of information, and therefore in engaging and participating in activities like this webinar this morning, and hopefully carrying this information forward to your colleagues and your staff and your residents. All of you have the potential to be powerful agents of information and agents of fighting the stigma and reducing the misinformation out there. So thank you very much for making that point very powerfully. And thank you all for sharing your voices. We'll have another section of time towards the end to hear from more, and I'm looking forward to that. But let's go into our next section, which is going to be addressing some of these myths and misconceptions about medication-assisted treatment and recovery. The first one, this first one has 4 different myths or misconceptions that are all sort of along the same line. MAR is not a legitimate pathway to recovery. Many people in the traditional abstinence-based recovery communities might espouse this opinion because it's not the pathway that they took, and they're negatively judging others who might need additional tools or different types of support to achieve recovery. If someone is on MAR, they're not really sober. If you use MAT or MAR, you're just not strong enough or ready for recovery. You're using a crutch. And finally, MAR only delays and disrupts true recovery. All of these are very judgmental statements and opinions. It makes me think of somebody sort of standing above and looking down and saying, your recovery isn't as impressive or as worthy of encouragement as mine. I was stronger in achieving my sobriety, and so I discount yours. The fact is that according to the National Alliance of Recovery Residences itself, MAR is consistent with abstinent-based approaches to recovery. When an individual is taking their medication as prescribed, is not using any illicit substances or alcohol, and is participating in a recovery program or community, they are fulfilling the expectations of an abstinence-based approach. NAR recognizes that medications are essential for some people to manage their cravings and engage effectively in long-term sobriety. In terms of 12-step groups, the official guideline or opinion of Alcoholics and Narcotics Anonymous is that they have no opinion on medication-assisted treatment. They don't take a stand on it. So although many of their more fervent abstinence-based members and participants in 12-step communities might have negative opinions about MAR, the actual head of the organization, the steering committee of the organization, has decided they do not have an opinion. They do not encourage anyone from being excluded because of their use of the medications. Next, here we heard this one already today. People doing MAR are just trading one addiction for another. As we discussed, when used as prescribed and under medical supervision, these medications do not get a person high. We'll go into more detail about this. We haven't covered that extensively yet, but that's an important point. A clinical dose of methadone or buprenorphine should not get a person high. It should be, a clinical dose should be what is required to keep somebody comfortable and to keep them from going into withdrawals and to keep their urges and cravings minimized. With Vivitrol, as we discussed, Vivitrol actually has no potential to get someone high. It absolutely prevents someone from getting high or from getting any pleasure from drinking alcohol. So what these medications actually do is to block the euphoric effects of opioids, relieve cravings, and normalize brain chemistry and physical functions. So an important point is that taking medications for opioid or alcohol use disorder is the same as taking medication for any other chronic condition like diabetes or asthma. When used according to a doctor's instructions, the medications will not create a new dependence. They're used to create a dependence that somebody has already developed, most likely through their use of illicit substances. Next, there's a misconception that these medications increase overdose risk. This is a harmful misconception. In 2020, there was a review of studies, a master study of as many studies as they could find that had already been done on this topic by Pew Charitable Trusts. And that master study concluded that individuals prescribed with therapeutic clinical doses of methadone or Suboxone actually have a significantly reduced risk of opioid overdose compared to those using illicit opioids. Two more. Next is that some people have the opinion or they tell others that these medications should only be used for a short time, maybe just to get you through the first week or months right after detox, but then you should stop these medications altogether. Actually, that is also a harmful myth. The fact is that longer treatment equals better outcomes. The standard for the duration of time of treatment with these medications is that the medications should be accessible to an individual for as long as that individual finds them useful for them. There's no research to support the use of these medications only for a brief period. And all decisions about the duration of treatment should be made between an individual and their treatment team. So I really would like to encourage everyone to not carry forth perpetuating, telling folks who do decide to take these medications that it would be better if they stopped them as soon as possible. Finally, there's a misconception that it's difficult to pay for medication-assisted treatment, and that many insurance plans don't cover the medications. The fact is that the Affordable Care Act of 2010, also known as Obamacare, actually requires insurers to cover addiction treatment, which in the vast majority of cases does include the medications for medication-assisted recovery. And we absolutely, in Washington state, all state provided or Medicaid insurance plans do cover the cost of medication-assisted recovery. So don't let anyone think that cost should be a barrier. Since 2010, since the implementation of Obamacare, every single person, regardless of their income, is eligible for health coverage. and that health coverage does cover these medications when prescribed through a licensed treatment program. Okay, the next section, we're going to talk about some of the nuts and bolts about the specific medications, both for opioid use disorder and alcohol use disorder. So I'm going to go through this. This might look like a somewhat intimidating table of information with a lot of tiny print here, but I'm not going to go through everything. As I said, these slides will be sent to everyone who registered today, and you can review it more on your own. But let's just hit some of the nuts and bolts about the major medications. So first of all, for opioid use disorder is methadone is the classic granddaddy medication to treat opioid use disorder. This is a full opioid medication. So it's what's called a full agonist. The idea with methadone is that you take methadone to keep yourself from going into withdrawal and to prevent having cravings, because the methadone completely fills the opioid receptors. However, a clinical dose is intended to be the dose that does not get a person high. It just keeps them comfortable or keeps them well, so that they're feeling okay, and they can then function well the rest of the day without being high, and without needing to satisfy cravings or prevent themselves from going into withdrawal. Methadone is taken daily, and most commonly it's a liquid, although sometimes it's a powder. The next one is buprenorphine, which has been gaining ground and becoming more and more common, and the choice of more and more individuals who decide to go the medication route. Buprenorphine is commonly known as Suboxone. Suboxone is actually buprenorphine plus naloxone or Narcan, as a misuse deterrent, as we talked about. And buprenorphine is actually a partial opioid medication. It's not a full opioid. It's a partial opioid medication that does bind to and fill the opioid receptors. However, it will never turn the effect of the opioids all the way up to 10. It'll keep it somewhere in the middle range. There's something called the ceiling effect with Suboxone. Once somebody has taken enough buprenorphine to fill their opioid receptors, taking additional amounts of it will not get them increasingly high. There's a ceiling effect. So this also works to prevent cravings and withdrawal. And it is taken, there's several different formulations. The most common is a daily film or tablet that is dissolved under the tongue. There's also a monthly injection formulation called Sublocade. And there's a 6-month implant, a little implant that can be inserted into your arm that will slowly time release the medication to you, called Probufene. Next is what somebody, I think Esther mentioned, Vivitrol. This is the clinical name is naltrexone. The brand name is Vivitrol. Also Revia is another brand name. This is a complete opioid blocker. Somebody has to be completely detoxed from all opioids for a minimum of 7 days before they can actually receive their first dose of naltrexone. So most commonly it's given at the tail end of somebody in a 7-day detox treatment program. And what it does, as I mentioned, is it sort of forms a cap or a seal over the top of opioid receptors. So it prevents other opioids, any morphine molecules from binding to the receptors. It also does help manage cravings for some, although some people report that they still do experience cravings for opioids after receiving Vivitrol. But psychologically, it helps them deal with the cravings by knowing even if I did try to use, it wouldn't have any effect. So what's the point? I better just find some distractions and know that over time the cravings will reduce. Vivitrol is most commonly given as a monthly injection in the butt. And one of the only side effects is soreness at the injection site. It is a rather large amount of medication that gets injected. for Revia, it's a pill form. Also, this is not considered a form of medication assisted treatment, but it's a good opportunity to talk about naloxone or Narcan, which I know that Walker has had Narcan trainings to train folks how to use Narcan and how to make sure it's on hand to prevent, to reverse opioid overdoses. But this is an extremely important and life-saving medication that is becoming more and more common. Insurances also cover this for anybody receiving prescriptions of other medications for opioid use disorder. They can request their pharmacy to also give them Narcan, and it's covered by insurance. This is an intranasal spray, so it's in a small bottle that you use your thumb to press up and spray it into the nose of somebody who's experiencing an overdose of opioids, and it will immediately kick off all of the morphine molecules off of their opioid receptors. It will also put that person into immediate precipitated withdrawal, so they will be extremely uncomfortable, but they will not die of an overdose. Frequently, there's more and more reports that for folks who are overdosing because of fentanyl, because of the strength and intensity of fentanyl, it might take 2 or even 3 doses of Narcan to revive them and help them survive. So a good point is to definitely have more than one dose of Narcan on hand or in your recovery residence or place of work. Not going to go into too much more of the neurobiology, but on this slide you can see in the small photos, the red liquid is what a daily dose of methadone looks like. Typically and traditionally, patients receiving methadone need to go to the methadone clinic and be supervised taking their daily dose at least 6 days a week. That is the traditional routine. We also see in the Suboxone picture, that is what the small piece of film looks like. Depending on what dose someone is prescribed, they may be prescribed between 8 to 24 milligrams of buprenorphine per day. And folks can either figure out what works best for them. Some folks take their entire dose at one time in the morning and feel that it carries them through the day well enough. Other folks break it up and take it at different times of the day at lower amounts. And then we see what Vivitrol looks like when it comes in the package, in the box. It needs to be refrigerated until it's injected, and it comes in a little bottle of clear liquid. Next, let's focus a bit on medications for alcohol use disorder. Because this is actually a very important topic, because these medications are severely underused in the treatment of alcohol use disorder. A statistic I found from SAMHSA is that of the 18 million people who met criteria for the diagnosis of alcohol use disorder in 2013, less than 7% of them actually received any type of formal treatment. And of that 7% that did receive treatment for alcohol use disorder, less than 9% of those were actually prescribed one of these medications. So all of the medications for alcohol use disorder are not alcohol substitution drugs. They're more like blockers. They're more similar to naltrexone or Vivitrol than to methadone or Suboxone. And the 3 medications are a Comprosate or brand name Comprol, which works by restoring homeostasis of the chemicals in the brain, restoring the natural balance of chemicals to reduce cravings and urges for alcohol. We can say basically in a way, it reduces somebody's motivation to consume alcohol, and this supports sustained abstinence. Next is Antabuse, which whenever I think of Antabuse, I sort of get an image of somebody vomiting profusely. Antabuse actually enforces someone's sobriety. It's like an alcohol vaccine. it actually inhibits the metabolization of alcohol. If somebody takes their dose of antabuse and then they do consume some alcohol, they have a severely unpleasant reaction, which can include nausea, vomiting, and heart palpitations. So it's sort of behavior modification by extreme discomfort. Folks for whom the threat of the supremely unpleasant reaction is not enough, the thought is that soon enough they will learn to form a negative association with alcohol, because anytime they consume it after being on antabuse, it causes such an unpleasant reaction. And yeah, that is a tablet that does need to be taken 1 time per day. And so unfortunately, with lack of ability to monitor or make sure that folks are taking their medication every day, somebody can decide, you know, I'd like to drink in a couple of days, so I'm going to stop taking my antabuse now and hope I won't have that negative reaction in a couple of days. That's a downside. And then there is naltrexone, Revia, or Vivitrol, the same medication that's used for opioid use disorders. But the way that it works with alcohol use disorder is that it basically reduces the pleasure. It takes away any pleasure or reward that somebody gets from consuming alcohol. And that's because of its interaction with our natural or endogenous opioid system. So effectively, it reduces cravings to consume alcohol because it makes drinking alcohol no different from just drinking water. And this, just as with the use of these medications for opioid use disorder, it can be given as a monthly injection in the gluteus muscle or a tablet taken once per day. All right, next, if you do have questions about these medications, something that we didn't cover or that you didn't see in the slide, please feel free to put it in the chat box, and hopefully we'll have time to address the questions at the end. But next, I promised that we would talk about some recent developments, some updates about these medications and about medication-assisted recovery. And I have 3 things that I think are pretty interesting and promising for the future of medication-assisted recovery. The first is what is known as the fentanyl vaccine. So this is currently being developed at the University of Houston. It's interestingly, it's being funded by the U.S. Department of Defense, not the American Medical Association or by pharmaceutical companies. It's actually the U.S. Department of Defense has determined it's worthwhile to fund the development of this vaccine for the safety and integrity of the entire country. Currently, this vaccine they've completed lab trials with rats and shown not only that it is effective in vaccinating against the effects of fentanyl, but also that there's minimal side effects. And currently, the application is with the FDA for human trials to start. The way that it works is that the vaccine creates anti-fentanyl antibodies that prevent the drug from entering the brain and making it impossible for somebody to get high or to overdose if they are exposed to fentanyl. And sounds familiar to COVID vaccines, but the way that it would be given is 1 dose and then 2 boosters. And somebody would be vaccinated for life from the effects of fentanyl. This is somewhat controversial. There's different opinions about whether this fentanyl vaccine is actually a good idea or not. On the positive side is certainly it would help prevent overdoses from drugs that have been contaminated with fentanyl, or from somebody who inadvertently does a lethal dose of fentanyl. It wouldn't kill them. Also, for folks who really do want to quit, this would be a permanent tool for them to make sure that they never have the effects of fentanyl again. On the negative side, or some of the concerns that have been expressed about this vaccine, the first one is that it could be given against someone's will or used coercively by prisons, parole programs, or drug treatment courts. this would be something of a human rights abuse, in my opinion, if it's given against somebody's will. And what we know about severe addiction is that then that would likely result in the development of other harmful addictions. Somebody who is driven enough to expose themselves to a harmful substance like fentanyl is likely doing it to seek relief from something pretty disturbing in their own life or psyche. And just taking away their ability to get high with fentanyl is not going to prevent their seeking that relief from other substances. And finally, the other concern is that actually what fentanyl was formulated for was as a very powerful anesthesia or pain management technique for surgeries in hospitals. If somebody were treated with the fentanyl vaccine, clinical fentanyl given by a doctor as anesthesia would no longer be effective for them. And the danger would be is that, for example, somebody could be in a car accident or some sort of a physical trauma, be unconscious, be taken to the hospital, be given fentanyl as the anesthesia, but then actually experience all of the pain, which is pretty horrific to consider. So positives and negatives, but this is in the pipeline. The next one is the loosening of methadone take-home restrictions. I mentioned that historically and traditionally, folks on methadone need to go to the methadone clinic 6 days a week and take their daily dose under supervision. At the beginning, in early 2020, at the beginning of COVID, SAMHSA began allowing states to request exemptions that allowed opioid treatment programs to give stable, what were classified as their stable patients, a month's worth of methadone to take home at a time. And for less stable patients or those who were more newly receiving methadone prescriptions, they were able to get 2 weeks of take-home doses. So this was quite a radical change that was made necessary because of the public health emergency. More than now 2 years later, now towards almost 3 years now, since that emergency declaration went into effect, when the opioid treatment programs could give folks much more methadone to take home and not requiring the folks to take it under supervision or to do regular urine drug screens, the feedback is that this change has resulted in increased patient satisfaction and increased retention in treatment, with relatively few cases of misuse or diversion. That's pretty surprising, but also very, very hopeful. And so now the SAMHSA has made it known that they are considering making this policy permanent. Even after the COVID-19 public health emergency declaration is no longer in effect, states can elect to allow all of the opioid treatment programs, all of the methadone clinics in their state to continue giving patients either 2 weeks or 1 month of methadone to take home at a time. And I can imagine that folks who are stable on methadone are very appreciative of this because it allows them to have much more normalcy in their daily routine. They don't need to go to the methadone clinic every day, and they can take care of their recovery on their own at home, and just need to check in once a month or every couple of weeks. Finally, we talked about how these medications so far are only approved for the use and treatment of opioid and alcohol use disorders, but there is promising research being done in identifying effective medications for the treatment of stimulant use disorders, especially methamphetamine use. First of all, to take a step back, there have been trials and research into medications to treat cocaine dependency. However, currently the findings, the results of those trials weren't very promising, because it was found that the anti-cocaine vaccine could be overridden by doing enough cocaine. So it was actually encouraging folks with severe cocaine dependency and addiction to just consume larger quantities of cocaine to override the vaccine, and that in the trials that resulted in high incidences of stroke and overdoses. So that's sort of on the back burner for this time. But more recently, the New England Journal of Medicine published the results of a 2-year MAT trial conducted with 403 individuals with methamphetamine use disorder. All of the volunteers in this research, they received daily doses of bupropion or Wellbutrin, which is an antidepressant, a pretty commonly prescribed antidepressant with few side effects. They received the daily Wellbutrin plus injections of Vivitrol every 3 weeks. And the results of that 2-year study were that folks experienced far fewer cravings for methamphetamine. They were able to lower their incidence of relapse and sustain their abstinence from methamphetamine, and also it increased their social functioning. So this is pretty promising. It will probably be at least several more years before this is actually approved by the FDA as medication for methamphetamine use disorder, but there are already reports of some providers and some clinics prescribing these two medications, Wellbutrin and Vivitrol, for folks who are struggling with methamphetamine use disorder. Okay, our next or final big section before we get to the next discussion is specifically about supporting folks who have chosen medication-assisted recovery in recovery residences. And the image you see here is actually the cover of a very, very good short publication. It's about 12 pages, but it's produced by the National Alliance for Recovery Residences. I'm gonna make sure that Brianna has it to hopefully send to you all with the slides from today's presentation. It's also available online, and this is a great resource to review and to also go over and discuss with your staff and possibly even your residents. But this publication goes over a lot of the best practices for accommodating folks on these medications in recovery residences, and also tips and suggestions. But basically, the takeaway is that the best practices is that recovery residences should foster inclusive, welcoming, and safe environments for all, regardless of whether or not someone is using or going on the pathway of medication-assisted recovery. So let's look at some of the tips that are given for screening and evaluating all residents fairly, regardless of whether or not they're using these medications as part of their recovery. The suggestion and guidance is that the screening procedures that are used to screen applicants who are hoping to become residents of your home should be consistent. You should be asking the same questions, the same criteria for every applicant. They should be fair and also documented, because this is somewhat of a legal issue. Somebody can claim that they have been excluded or discriminated against because of their use of these medications. So it's important and helpful to have documentation of your screening procedures for all residents. Also, it is important to make clear during initial interviews with all residents, not only, of course, your residents on medications, that your expectations for them or your requirements for them to participate in recovery programs and residence activities, whether or not they're using these medications. The requirements should be the same for all residents. And finally, this goes without saying, to avoid excluding anyone based on their use of any type of prescribed medication, whether it's for diabetes, a heart condition, or an opioid or alcohol use disorder. To do so is a violation of federal law. The law requires us to find ways to accommodate and do our best to keep everyone safe in a recovery residence, whether or not these medications are present. I just want to take a moment. This was on my mind about whether I should discuss it or not, but I think it's worth mentioning just as an anecdote. But I know that Oxford House is separate from Walker credentialed recovery residences. But when I was working with a behavioral health agency in King County previously, I had several colleagues who were in long-term recovery themselves and who were quite close with Oxford House as an organization and also specific Oxford houses. And they shared with me that although the Oxford House leadership was aware that it was against the law to discriminate against anyone taking these medications from or being approved for residents in an Oxford House, the way that they got around that was finding something else, finding some other reason to exclude someone. And I was just extremely disappointed in hearing that sort of workaround was openly being discussed or, encouraged. And certainly trust that Walker as an accrediting organization and that all residences that are under the umbrella of Walker would hold themselves to higher standards and seek to not engage in that kind of discriminatory behavior. So next, 3 more tips for screening folks fairly. This is from NAR, from the National Alliance, but they encourage every house for their primary screening criteria, for the basis of all of their screening criteria should be based around ensuring that all applicants' recovery goals align with your residence's philosophy and the services and support that you can offer or that are available in your community, regardless of medication status. So that's really a good philosophy to hold close when you're designing your screening procedures. Finally, 2 more tips about what's good to inform applicants about. It's good to inform applicants that they may be asked to give your staff permission to communicate with their prescriber, with their MAR prescriber or their treatment team. It's a good idea to have the ability to have 2-way communication and explain that is actually in the best interest of supporting the health and recovery of the individual, not trying to interfere, but just having the ability to check in or to clarify share any concerns or clarify any gray areas. Also, it's important to make it very clear to applicants what your home's medication management and safekeeping policies and procedures are. So this goes back to the 2-way communication piece. Coordination between staff of recovery residences and opioid treatment programs or other MAR providers. First principle is that all decisions about the treatment with these medications should be made between the individual and their prescriber or their treatment team, without much or any influence from staff or residents in the recovery home. It's an individualized treatment approach. However, that being said, recovery residents, operators, and staff should have a clear understanding of each MAR resident's dosing, what their daily dosing consists of, and the frequency of that dosing, and also the length of their prescription. How frequently are they expected to keep appointments and check in with their treatment team? That is helpful for the recovery, for the housing side to know, to actually be able to support the resident. Also, it's important for the housing staff to have a clear understanding of the impact of these medications on a person's daily activities. For some folks, after they take their dose, they might have low energy for a certain amount of time. Rather than jumping to the conclusion that they've taken higher than a clinical dose and they're nodding off, it's helpful to check in with their treatment team and know if that is a documented typical effect for what happens with somebody when they just take their prescribed dose. And also, if there's concerns about the effects of the medication with what you're observing in the house, that is also very helpful to share and discuss with the individual's treatment team. So the way that two-way communication is made possible is that the actual resident needs to sign what's known as an ROI, or mutual release of information. And there's actually a law for this because of HIPAA and the protection of private and protected health information. It makes it necessary to actually have a signed legal document from the individual allowing sharing of information between their housing team and their treatment team at the clinic. And so there's a link here to what that sample document looks like. I would encourage all recovery residences to have a version of this release of information form ready to create and provide for the individual to consider signing. It's also more than likely that their clinic or their opioid treatment program will already have this legal document, and you can ask the resident to check in about that with their treatment team and to sign it for the recovery resident staff. All right, next step is next chunk of suggestions is about preventing diversion, making sure that these medications are only available to the person who they are prescribed to, and that they don't find themselves in the community for other means. As we talked about, both methadone and buprenorphine do have street value, potential for misuse, and potential for overdose. So it's critically important for the safety and well-being of everyone in the community that these medications are only available for those who they are prescribed. Because of this, it's very important that every residence have clear medication management policies and procedures, and that every single staff member be thoroughly trained in following those policies. A good tip is to have lock boxes for medications, not necessarily only medications for treatment of use disorders, but every individual's medications can be kept in lock boxes. The residents themselves must be able to access their medications. But for example, if there's two keys or one combination for the medication lockbox, the key or the combination, the resident can have one and the staff can have one, but other than that, nobody else is able to get into the medication. Also, it's very valuable to be aware of the warning signs of inappropriate use of these medications. Be aware that taking a higher than clinical dose of specifically methadone and buprenorphine can result in drowsiness, lethargy, mood changes, disengagement with housemates, not wanting to participate or socialize. That could be a warning sign that something's not going as planned or as prescribed with the medications. And it's NAR doesn't make any formal recommendations on this, but recovery residences themselves can consider making it policy to have regular med checks where you check how much of somebody's medication is remaining at any time, knowing how much they're prescribed per day and checking in to see is that what you have since you last got your refill, and also to consider random drug testing. All of these are meant to prevent the risks that unfortunately come along with the use of these medications in recovery. And finally, fostering a MAR welcoming culture in general among recovery residences. A great tip is to start with information like that which is provided in this webinar, and to also start with your staff. Share this information with your staff. Share the publication from NAR. Ask your staff to watch the recording of this webinar or to review the slides. And then once that information is carried forward to your staff, you can then engage residents, whether they're on these medications or considering these medications or not, it's helpful to make everyone more informed and more supportive and welcoming of folks who have chosen medication-assisted recovery. Also, early intervention. By that, I mean preemptively discussing with your staff and your residents any concerns, any opinions, positive or negative, that they have about these medications and about residents on these medications, and seeking to problem solve and open that dialogue proactively rather than waiting until something blows up. And finally, it can be very helpful to seek out and enable connections to MAR welcoming treatment providers and recovery support services in your local community. So I know that Walker has had presentations from folks from Peer Spokane, Peer Olympia, Peer Seattle, and all of those peer-based services are very welcoming for folks on medication-assisted treatment. There's also MAR Anonymous meetings. As somebody mentioned, every NA meeting, every NA community and AA community has a different culture and a different feel. So finding those meetings where folks are open-minded and welcoming of folks on these medications can be very helpful and beneficial for your residents. And finally, we have a couple minutes left for discussion again. At this time, it will be a great time if anybody has any specific concerns that you'd like to share or discuss about MAR in your recovery residence. Also, if anybody has any tips or suggestions about what they found helpful about supporting folks on MAR in their residence, if you could share that, that would be wonderful. So, Brianna, yes.
One piece that I want to bring up and touch on a little bit, I guess the discrimination that you've been hearing of going on in the Oxford houses. To be honest, it's troubling to me. Oxford House can be a great organization and serve many individuals in recovery. I know in the beginning of when Matt and Mara first came out and was on scene, there was a whole heck of a lot of discrimination going on within the Oxford House around that model. I know that the staff, the outreach services representatives, the senior staff have went a long way to try and educate all of the individuals living in the houses to break down those stigmas, to break down those fears. It's just troubling that a bit of that is still out there. There's some great senior staff with Oxford House, and if any of the providers on here today are still running into discriminatory things around Matt and Mar in any of the Oxford houses, Richard Mogul, a great guy, he is down in the King County area in Seattle. I'm going to put his contact information in the chat for any of you to be able to reach out to him. At the end of the day, you know, when I was one of those people in the very beginning who was, what do I want to say, who lacked understanding. I didn't have a clear concept of what Matt and Mar was. And openly, I was one of those individuals who thought maybe it wasn't the best thing to have in recovery residences. Since that time and working over a decade with recovery residences, I've educated myself, a lot of training. I've had a lot of individuals that have been close to me, a lot of loved ones out there that have greatly benefited from Matt and Mar. And it's a tool. It's a tool that can be used for recovery. As Julia said, it can be a gateway to recovery. The implementations and the help that it can provide the many millions of people out there in this world now have just been astonishing. Thanks.
Yeah, thank you, Jason. I see a hand raised from Joyce. I'd like to give her a chance, but also a message came in from, and now Jessica's hand is raised. So let's give Joyce a chance to share, and then Jessica.
I work with a lot of Oxford homes, recovery homes. We still have one major provider that how they get around the Suboxone issue is they will accept a patient that is in MAT, but they're not allowed to have their Suboxone on site. So the major issue is that now puts a person in a position of having someplace to live or being in recovery. And it's an uphill battle that we're still having. And I don't know how to get around it because I don't want to ever put somebody in the position of having to make that choice.
Yeah, it's a horrible, horrible choice to have to make.
To be honest, Joyce, nobody should be put in that position to have to make that choice. I'm gonna put Richard Mogul's contact information here for the Oxford houses. I'm gonna put my direct contact number here as well, if in case anyone ever experiences that in any of our Walker accredited houses. Again, it's just very disturbing to hear that it's still happening, and I apologize.
It's not with the Walker. I want to make that clear. To be honest, it's a House of Mercy because they're Christian based. They have decided because of issues that they've had with Suboxone on site for so many years that a person cannot bring their Suboxone. So if they happen to be on Sublocade and their UA is positive, that's okay as long as their medication is not in the house. And again, you know, it puts the person in position of making a decision on whether they have a roof over their head or whether they have a safe recovery path. So it's a frustrating thing. And I understand where they're coming from because obviously diversion is a big deal. Selling is a big deal. You know, all those things that come with any opioid issue. However, it's still going on. And I guess that's where my frustration is. And so having people to talk to or to reach out to really is helpful.
Yes, thank you. Thank you, Joyce, for sharing your frustration. Thank you, Jason, for sharing your passion towards increasing equity and reducing discrimination. And I want to say my hope comes from, my optimism comes from feeling that there is an evolution in thinking about this topic, and all of you here today are part of that evolution. So I appreciate that. Next, Jessica.
Hi there, everyone. My name is Jessica Bloss, and I'm the current Washington State Opiate Treatment Authority, and I actually have oversight over all opiate treatment that's used with opiate medication. So I just want to thank all of you for being involved with this conversation today. For those of you who are coming here to learn more, we really need all of you as our most important housing types of providers, you know, to help us meet the needs of our patients. And this issue of access and stigma and even discrimination is something, you know, we're still widely dealing with. I want to point out that I also added my contact information in the chat. At the Washington State level, we also will have one-on-one free technical assistance meetings with any recovery house that might be interested in reaching out, and we'll have a virtual discussion with you to talk about how you can help update your policy and procedures, or talk what topics to talk about with staff training, things that can help make you have an easier time, hopefully, with the updates you might have to make, again, with policy and procedures. So please don't hesitate to reach out to me. And then I guess I will also say, while I'm sure maybe not everyone would want to do this, if there are ever concerns about specific organizations and there's a desire to, you know, report something, so the state could follow up with that provider one-on-one and see how we can help them make changes, you could also contact my office there. But anyways, I did put my contact information in. And again, I just so appreciate all the discussion today and the amazing work you're doing. And I'm excited to see how things can continue to get better, even more so in the future in this area. So thanks, everyone.
Yeah, thank you so much, Jessica, for making that generous offer and also for joining us today. Just before I hand it back over to Brianna, I think hopefully, Brianna, you're able to share both Jason and Jessica's contact information when we send out the slides and other information to
Yes, I can definitely do
participants.
that. Mhm.
Great. I also just want to respond because I see a comment from somebody that shared their concern that we might be unfairly painting Oxford House in a negative light simply because of of what might be anecdotes or just the actions of a small number of individuals that are connected with Oxford. I absolutely acknowledge that. I'm glad that Jason mentioned all of the great work that Oxford is doing. It's fundamental in our community that Oxford houses our robust presence. And yeah, it was not my intention, or I believe anybody else's intention, to paint Oxford House with a broad swath. And we wouldn't want to stereotype Oxford houses, just as we don't want to stereotype anyone involved with Matt. Okay, and with that, I just want to thank you one last time. Hope you all have a great, wonderful day and rest of the weekend. And now hand it back over to Brianna.
Yeah, so I just want to thank you guys as well for being here today. Again, I will send you guys the slides as well as a link to the video recording to the emails you registered with. And just to stay up to date with some of our upcoming webinars, go to walker.org/events, and you can always register there as well. And I will send everyone's contact information. I'll mention Jessica and Jason. And thank you. Thanks for being here.
Bye-bye, everyone. See you next time.
Thank you all.